Hello, my name is Professor Graham Collins from Oxford. I'm delighted to be kicking off this Lymphoma Action course on lymphoma management. We do this every year, and most years I do this talk on why lymphoma is so interesting. And despite the many years of being in lymphoma medicine, I still find lymphoma an absolutely fascinating disease with an absolutely fascinating modality of treatments that we apply to lymphoma. So without further ado, let me try and explain why I think lymphoma is so interesting. Well, there's not one reason, there's four reasons that I will try and persuade you of. Its biology, its epidemiology, its diverse clinical features, and the wide array of treatment strategies. So first of all, biology. Now, for any hematologists who are listening, you'll recognize these as the main circulating white cells that we have in our blood. The neutrophil is quite an interesting cell, isn't it, with its multilobulated nuclei there, the eosinophil with its bright pink granules, the basophil with its darkly staining granules looking like a squashed up neutrophil, and the monocyte with its lovely sky blue cytoplasm. And then we have the humble lymphocyte, which on the face of it looks like a rather boring cell, quite small, a bit bigger than a red cell, rather nondescript nucleus and a small amount of cytoplasm. But actually, it belies what I think is the most fascinating cell in the human body. Lymphocytes have a wide array of functions, all related to the immune system. They produce antibodies, they present antigen to the immune system, they coordinate the immune response, they suppress the immune response, they directly kill virally infected cells, and they're involved in tumor surveillance and suppression. So they're a truly fascinating cell. Now, one thing about lymphoma is there are so many different types. It can be very confusing for patients sometimes when they're just diagnosed. And why are there? Why is it so complicated? Well, it's partly at least because of the complexity of the life cycle of the B lymphocyte. Most of our lymphomas derive from B cells, and a B cell has a complicated life cycle. Now, I often compare this to bowel cancer. You know, bowel cancer, I've got nothing against bowel cancer, but it's a rather boring type of cancer. There's only one main type, and it's quite boring because the cell it arises from, the bowel epithelial cell, is a rather boring cell. You know, starts off in the crypt of a villus, goes up to the tip, sloughed off in the feces, and that's about it. Whereas the B cell has a very elaborate life cycle. It starts off as a stem cell, hematopoietic stem cell. In the bone marrow, it differentiates into a naive B cell, which hasn't yet encountered antigen, but it has an IgM, an antibody molecule in the surface of the membrane. It then moves to the spleen, where it undergoes further development as a transitional B cell. It can stay in the spleen as a marginal zone B cell, these B cells that respond to antigen in a T cell independent way, and can lead to very rapid production of antibody to encapsulated bacteria. Or it can either stay in the spleen or go to lymph nodes and become a follicular B cell. Initially, you have a primary follicle, which is just naive B cells all clumped together. But then when antigen is presented to these B cells, then the party really starts and you get the development of a secondary follicle, and that's characterized by the germinal center. And the germinal center is where the antigen is presented to a B cell. You get lots of cell death, you get lots of differentiation, and spat out the other side of the B cell, you get a memory B cell, which can respond much more quickly to a repeat exposure of the antigen. Or you get a plasma cell, which is a specially designed cell for antibody secretion. And in order for that plasma cell to survive, it completes its journey home back to the bone marrow, where there's a niche for long-lived plasma cells, and they can sit there secreting antibody for many, many months and years. So that's the complicated life cycle of a B cell, and you can roughly equate, I have to say this is an imperfect science, but you can roughly equate the diseases that we see to where they arise in that life cycle. So a problem in the bone marrow can lead to acute lymphoblastic leukemia. Now we're not going to discuss that further in this course. A problem in the spleen there, in the marginal zone in the spleen, can lead to splenic marginal zone lymphoma. A problem in the mantle zone, which is the squeezed out bit of primary follicle that you see when a secondary follicle develops, can lead to mantle cell lymphoma. The germinal center, though, is really where most of our lymphomas come from. So follicular lymphoma and diffuse large B-cell lymphoma, certainly the germinal center subtype, plus Burkitt lymphoma, which is quite uncommon. But those three all arise from the germinal center. And then just post-germinal center, we get another two relatively common subtypes, Hodgkin lymphoma and the ABC subtype of diffuse large B-cell lymphoma. So the germinal center is where the majority of our lymphomas come from. A little bit further towards a plasma cell, we may get LPL or lymphoplasmacytic lymphoma. And then as a cell develops into a memory B cell, this is postulated at least as a possible origin of mutated CLL. And a bit earlier in the pathway is the postulated cell of origin of unmutated CLL. And then, of course, further on in the bone marrow, when you have a terminally differentiated plasma cell, if that cell becomes cancerous, you get myeloma. And again, that's such a sort of different disease than lymphoma that we won't discuss it further in this course. Now, this just shows you the structure of a lymph node. So you can see the afferent lymphatics, in other words, the lymphatic fluid coming into the lymph node. And the first thing it comes across is the cortex, and that's where you find these follicles. You can see these follicles on the right. These follicles are round structures. This is a very reactive lymph node you see here because these are all secondary follicles. They've got that dark mantle zone around the outside and the pale germinal center on the inside. And the cells in between those follicles are basically, that's the paracortex, that's basically T cells there. The follicles themselves are B cells. And then that germinal center is a really critical structure in the development of lymphoma. You can see here on the left, the naive B cell going into the germinal center. It gets antigen presented by the follicular dendritic cell. And then if the antibody stuck in the surface of that naive B cell does not recognize the antigen, it dies. And that's the majority of B cells. So most B cells just die of apoptosis. But those that do recognize the antigen are selected by T cells provided with T cell help. And they, as I say, become either a memory B cell or a plasma cell. But on the way, they undergo two genetic events. One is class switch recombination, which is where your IgM molecule changes into an IgG or an IgA, and that involves a double-strand DNA break. But you also get somatic hypermutation, where single mutations are introduced into the variable portion of the immunoglobulin gene, and that modifies the specificity. Those that have a less specificity for the antigen die, whereas those that have more specificity, again, are positively selected, and you get better specificity of your antibody against the antigen. However, somatic hypermutation involves a single base pair mutation in DNA. Now, normally, cells recognize when there has been DNA damage, takes the cell out of the cell cycle with p53, for example, and the cell either repairs the DNA or it dies by apoptosis. But you don't want that to happen in a developing germinal center B cell because it needs to react and grow and divide and respond to the antigen. So actually, DNA response and repair mechanisms are repressed in a germinal center B cell. So if one of those genetic changes, those physiological genetic changes goes wrong, then that's not recognized and you can potentially develop a lymphoma. And it's usually the somatic hypermutation that goes wrong. You can see the footprint of somatic hypermutation happen on oncogenes in many lymphomas that arise from the germinal center. So the germinal center is a fairly dangerous place for a germinal center B cell, and that's where the majority of our lymphomas arise. And that's why B cell lymphoma is so much commoner than T cell lymphoma, because T cells don't undergo a germinal center reaction. Now, I've mentioned the complexity of lymphoma. It is complex. Lymphomas are described by actually two classification systems we have now. I've only mentioned the WHO one we have here, and actually there's been an update since this picture. It describes many different lymphoproliferative conditions. It's very long and it's quite expensive. So what's a better way to understand lymphoma classification? Well, this is a more simplistic way, and I'd encourage you to try and commit this to memory. So lymphoma, which is a cancer of T or B lymphocytes, is split into Hodgkin or non-Hodgkin lymphoma, first described by this great man here in this picture, Thomas Hodgkin. And Hodgkin lymphoma is nearly always classical Hodgkin lymphoma with its characteristic Reed-Sternberg cell, but a small number, a small proportion, about 5% maybe, is the much rarer nodular lymphocyte predominant Hodgkin lymphoma, which behaves a bit more like a low-grade non-Hodgkin lymphoma. So that's Hodgkin lymphoma, relatively straightforward. Non-Hodgkin lymphoma, far commoner. We split it into T cell and B cell. B cell is probably 90% plus of the non-Hodgkin lymphoma we see, and we split those into high-grade and low-grade B-cell non-Hodgkin lymphoma, and then each of the individual sort of subtypes fit into those buckets. So high-grade is diffuse large B, it's Burkitt's, it's lymphoblastic lymphoma. Low-grade, follicular lymphoma, marginal zone lymphoma, LPL. I've rather controversially put CLL or chronic lymphocytic leukemia into that low-grade B-cell non-Hodgkin lymphoma bucket because biologically speaking, that's basically all CLL is, a low-grade B-cell non-Hodgkin lymphoma, albeit with some certain unique features, which is important to know about. So that's how I would encourage you to think of in terms of classification of lymphoma. And this is useful because actually all high-grade lymphomas behave in a similar way and are treated in a fairly similar way. And all low-grade lymphomas have certain characteristics which they share and so certain management strategies that are applied. So what do I mean by that? Well, this is the characteristics that low-grade non-Hodgkin lymphomas share. They're slowly progressive. Their incidence increases with age. You almost never see low-grade non-Hodgkin lymphoma in children. Never say never, but it's very, very rare in children. There's usually no cause. That applies for all lymphomas, but just occasionally there are very specific causes. So H. pylori can cause gastric malt lymphoma. That's important to know about, because if you eradicate H. pylori in someone with gastric malt lymphoma, you can cure their disease. Generally, low-grade non-Hodgkin lymphomas are not considered curable with chemotherapy, although there are some rare situations where we may go for cure. Treatment is actually quite variable with low-grade non-Hodgkin lymphomas. We might use single-agent antibodies, we might use targeted therapies, multi-agent chemotherapy. But even without treatment, many patients can live for many years, and actually a watch and wait strategy where we just keep an eye on patients with asymptomatic disease is applied to pretty much all low-grade non-Hodgkin lymphoma in the appropriate patients. So those are the shared characteristics of low-grade. How about high-grade? Well, high-grade, again, it increases in incidence with age, but we do see it in children. Again, usually no cause, although HIV is a risk factor. Big difference. We do frequently cure high-grade non-Hodgkin lymphoma with immunochemotherapy, so chemotherapy combined with a monoclonal antibody. Without treatment, patients don't survive long, so it's important to diagnose this quickly and treat, and that's because it's rapidly progressive. So that's the sort of shared characteristics of high-grade. The epidemiology of lymphoma is another fascinating feature of lymphoma. So the incidence of non-Hodgkin lymphoma, as you can see over the last sort of 40 years, has been increasing, particularly in the 1970s, 80s, early 90s. It's leveled off a bit, but is still rising just at a slower rate. Hodgkin lymphoma, the incidence is relatively static. So there does seem to be something unique about non-Hodgkin lymphoma, and we're really not sure what has caused that rise in incidence. Maybe partly developments with diagnostics, but we haven't seen a similar thing with Hodgkin. So I think there's more going on than that. There's a very interesting geographical variation. So here in the sort of Western world, if I can put it like that, Western Europe, North America, we tend to see mature B-cell lymphomas, follicular lymphoma, diffuse large B. T-cell lymphomas are pretty rare. Go to the Far East, Japan, parts of Asia, also some parts of South America, and HTLV1 associated T-cell lymphomas are much more common. You also get other rare types of T-cell lymphoma, rare at least for us, such as extranodal NK T-cell lymphoma. So there is this interesting geographical difference. And of course, endemic Burkitt's is really only seen in sub-Saharan Africa, in children particularly who live below certain altitudes. So very specific sort of epidemiology for that specific disease. What about in the UK? Well, this is data from the Leeds and Yorkshire group, the HMRN, showing if you include CLL, CLL is probably the commonest lymphoma subtype, followed by diffuse large B-cell lymphoma. In terms of low grade, most studies would say follicular lymphoma is the commonest low grade. Slightly oddly, marginal zone is reported as the commonest in the HMRN website, but I think, if you look at most publications, it's follicular lymphoma. So diffuse large B, follicular, and then probably Hodgkin after that. What causes lymphoma? Well, most of the patients we see, there is no obvious cause at all. There are some associations though. So viruses such as Epstein-Barr virus, which lives in B cells, it certainly can cause endemic Burkitt lymphoma, which I say is mainly seen in sub-Saharan Africa. 50% of cases of classical Hodgkin lymphoma have EBV in it, but of course the vast majority of people who have EBV never get Hodgkin lymphoma. And probably a majority, relatively slim majority, of post-transplant lymphomas also have EBV as an important part of their etiology. HIV is certainly a risk factor for lymphoma, particularly the aggressive forms, Burkitt, diffuse large B primary CNS lymphoma. We see less of that with highly active antiretroviral therapy, however. HTLV1, human T-cell lymphotropic virus 1, is another retrovirus, which I've already mentioned is associated with adult T-cell leukemia lymphoma, or ATLL, a very specific type of T-cell lymphoma. And there are also reports of hepatitis C being associated with splenic marginal zone lymphoma. Bacteria, well, I've mentioned H. pylori and gastric malt lymphoma is a well-known association, and another bacteria, Chlamydia psittaci, is associated with ocular adnexal malt. But I have to say, both of these types of malt lymphoma, you can certainly get H. pylori negative cases of gastric malt, for example. So it's not invariable that you see these bacteria associated with these conditions. Immunosuppression generally, now I've mentioned HIV, but also post-transplant states in HIV negative patients who have immunosuppressive drugs, that is a risk factor for the development of lymphoma, and certain autoimmune conditions. And again, we're back to MALT lymphomas here, mucosa-associated lymphoid tissue lymphomas. It seems to be that chronic inflammation, whether it's caused by bacteria such as H. pylori or autoimmune conditions such as thyroiditis, can lead to the development of these low-grade MALT lymphomas. But again, most cases do not have an identifiable cause, vast majority of cases. Another reason why lymphoma is so interesting is its clinical presentation. I only have one slide on this. Suffice it to say that lymphoma really can affect any area of the body you care mention. Top left here is an ocular MALT lymphoma. Top middle, you've got a cardiac lymphoma, usually high grade. Top right, you've got a bony lymphoma, again, often high grade, but not always. Bottom right, you've got primary CNS lymphoma here, and with quite a periventricular distribution, quite difficult disease, although great strides recently in its management. Middle on the bottom is a cutaneous T-cell lymphoma and also a diffuse large B-cell lymphoma of leg type. And then on the bottom left, we've got somebody presenting with a large mediastinal mass, which is can be a medical emergency. So really keeps us on our toes as clinicians. Very difficult also to say that somebody doesn't have lymphoma, because really lymphoma can produce most symptoms that you care think about. So it's a very interesting clinical condition. And then the final answer that I've got is the wide variety of treatment modalities that we employ. Some are, well, by definition, almost completely harmless, i.e. watch and wait. So we don't do anything to the patient apart from just keep an eye on them. But on the other end, we've got allogeneic stem cell transplant, which is probably the riskiest thing that we do in our hospitals, with a mortality rate of 15 to 20%. And we've got a big spectrum in between, from single agent monoclonal antibody or single agent oral chemo. We've got targeted therapies such as BCL2 inhibitors, BTK inhibitors. We've got immunotherapy such as PD-1 inhibition, particularly in Hodgkin. We've got lots of antibody drug conjugates that we use now, diffuse large B-cell, Hodgkin lymphoma. We've got immunochemotherapy, so rituximab and obinutuzumab combined with various chemotherapy regimes, some relatively mild, some a bit stronger. We've got quite intensive chemo, such as escalated BCOP or BCOP-DAC we use for Hodgkin, or relapse diffuse large B type treatments. And more recently, we've got cellular therapy, such as chimeric antigen receptor T-cell therapy, very exciting new form of treatment that is now available as standard of care in some types of relapsed lymphoma. And happily, progress is being made. I find Lymphoma Clinic a very optimistic place to work. You can see here the age-standardized mortality rates, which initially rose, again, in the 1970s, 1980s. That parallels the increasing incidence of non-Hodgkin lymphoma, but it's peaked. And despite the incidence still rising, albeit at a slower rate, the mortality rates are falling. And one thing, obviously, we hope that this course will do is help contribute to the education of the best management of lymphomas, but also to keep that mortality rate falling. And that, of course, needs our active participation in research as well. So I hope that's whetted your appetite to why lymphoma is so interesting. I really do hope you enjoy this course. And without further ado, we'll move on to the next talk. Thank you very much.
My name is Kathy Burton. I'm a consultant haematologist at St James's Hospital in Leeds. I'm going to be talking about integrated lymphoma diagnostics. I'd very much like to thank Toby and Graham and Lymphoma Action for asking me to speak at this session. So why is integrated diagnostics important? We know for some time that there is significant discordance between general pathology labs and specialist hemato-oncology labs. This was reviewed really 2 decades ago now, and then with various other papers have looked particularly at the expert clinical review in the diagnosis of lymphoid malignancies, and that there is more concordance between hematopathologists, and therefore it makes sense that there should be regional specialist labs in hematopathology that diagnose hematological malignancies. And the important thing in terms of these diagnostic labs is that they generate a single report, but this incorporates all important data relating to a hematological malignancy. And this was reviewed and reported in the NICE guidelines, Hematological Cancers Improving Outcomes, in 2016, which looked particularly at dual reporting, i.e. 2 pathologists reporting hematological malignancies, and also involving these pathologists in NDT participation, so that the clinical information was also used in association with the diagnostic material to generate a report that describes exactly the clinical and pathological entity. And so in HMDS and in most hematological malignancy diagnostic services, a single IT system is used to generate a report that summarises all elements of a laboratory diagnosis for a specific patient episode based on results in terms of cytology, the histopathology, the immunophenotyping, either by flow cytometry or by immunohistochemistry, cytogenetics, FISH results, and molecular genetics. And this is in accordance with the current World Health Organization diagnostic classifications of hematological malignancies. So this WHO classification is really the textbook or the Bible that we use for diagnosing lymphoid malignancies. And this is fundamental in terms of using this classification for identifying the correct treatment for individual patients, for monitoring global disease incidence, and also for investigating all aspects of disease causation, prevention, and therapy. So this WHO classification we've used for a number of years. In 2016, this was revised for lymphoid neoplasms. This was the 4th edition. And what this particularly looked back at in 2016 is expanding in terms of the diagnosis of lymphoid neoplasms, expanding the genetic and molecular landscape, and acknowledging that more was known about this and the associated clinical correlation, that using molecular information was allowing us to subclassify and reclassify lymphoma, and that this also led to investigations so that more targeted therapeutic strategies could be used. In 2022, there was a further revision of this classification, the 5th revised edition, and this really acknowledged even more the increasing importance of genetic and other molecular data, realizing that diagnostic resources were not universally available, and therefore that diagnostic criteria should be defined for each entity in terms of the essential criteria, which are the minimal criteria allowed for a diagnosis of an entity to be made, and then desirable criteria that would aid in confirming or maybe refining the diagnosis so that the most specific diagnosis for an individual patient could be made. So in terms of making a diagnosis of a lymphoid malignancy, these are the general diagnostic tests that are performed: immunohistochemistry, immunophenotyping by flow cytometry, FISH, PCR, looking for single point mutations, chromosomal translocations, for example, the 14/18 translocation in follicular lymphoma, gene expression, looking for fusion proteins, and particularly looking at clonality, which can be very helpful in terms of confirming a malignant process. Also, transcriptome sequencing is becoming increasingly important in the diagnosis of lymphoma, using either targeted panels or more whole genome sequencing. So what I'd like to do now really is just talk about some of the specific entities within the diagnostic laboratory that we look at and how we approach the classification and diagnosis of these entities. So first of all, I'd like to start with aggressive B-cell lymphoma. And this was the 2016 WHO classification. This is a diagram showing how aggressive B-cell lymphoma was separated into diffuse large B-cell lymphoma, high-grade B-cell lymphoma, and Burkitt's lymphoma and other entities. And I'll talk about the first 3 entities mainly for this talk. So in 2022, as I say, there was a 5th revised edition, but really this still described diffuse large B-cell lymphoma as generally being divided into 2 groups: activated B-cell type and germinal center B-cell type, as well as the unclassified type. Describing GC versus ABC lymphomas, there's clear differences between these 2 groups, allowing these 2 entities to be quite easily described. So the GC subtype, the GC shows a certain gene expression enriched for the IGH-BCL2 fusion, and the mutations seen in the GC subtype are involved in GC development, dark zone and light zone transitions, and the microenvironment. And these particular genes listed here are commonly seen in the GC subtype. In the ABC subtype, E cells are different in that they derive from exit from the germinal center or have post-germinal center origin. They're dependent on other signaling pathways, for example, the BCR and NF-kappa B activities, and they are negative for most germinal center markers and tend to express IRF4 or MUM1. And they're enriched for certain mutations, for example, MYD88, and other mutations involved in the BCR pathways, and also mutations that block B-cell differentiation, so BCR6 rearrangements and BLIMP1 mutations or deletions. This was demonstrated quite clearly in the Remodel B trial, where patients were separated by real-time gene expression profile into either GCB, ABC, or unclassified, and 73% of patients had a detectable mutation in one or more genes, and we were able to demonstrate the mutations such as EZH2 was restricted to the GCB category. There were mutations that were more common in GCB, like CREB-B, MML2, and DDX3X, and other mutations like MYD88, 79B, and PRDM1, significantly associated with the activated B-cell type. And so what this has really led us to know in terms of the genetic subgroups of diffuse large B-cell lymphoma is that they can, by gene expression, be divided into the ABC, GCB, and unclassified type, but then they can be further subdivided by their mutational profile, as demonstrated here, and what the size of the subgroup circles approximates the proportions of patients in each group. So you can see within the ABC group that MCD and BN2 are the greater proportion of patients, when the GCB group is particularly the MYC negative and BN2. What this allows us to do is identify particular mutations which potentially allow us particular therapeutic options, or at least give us prognostic information in terms of how patients will respond to first-line therapy. What's important to note, though, from this diagram is the other group at the bottom here. So this makes up 37% of patients. And although we can subgroup the vast majority of diffuse large B-cell lymphoma patients, there are a significant proportion that still cannot be fully classified, and therefore further work is needed in this area. So moving away from diffuse large B-cell lymphoma and onto Burkitt lymphoma, in terms of making the diagnosis of Burkitt lymphoma, this is a B-cell lymphoma with a germinal center phenotype, so CD10 positive, BCL6 positive, with no expression of post-germinal center markers like IRF4 or MOM1. Generally, this is BCR2 negative. That's one of the hallmarks of Burkitt lymphoma, with a high proliferation rate of Chi67 score of between 90 and 100%. The vast majority of patients with Burkitt lymphoma have the 814 translocation, so 80% have this, the MYC translocation, with a small group having the 28 translocation, the kappa light chain, and an even smaller group having the 822 translocation, the lambda light chain. And generally, Burkitt's lymphoma are divided into those that are EBV positive and those that are EBV negative. And those that are EBV positive have higher levels of somatic hypermutation, fewer driver mutations, and lower frequency of certain mutations such as TCF3 and ID3. So in terms of making the diagnosis of Burkitt lymphoma, the most important thing is considering this in a patient with a large B-cell lymphoma with blastoid morphology, a high proliferation rate, a germinal center phenotype, and BCL2 negativity. And FISH should immediately be performed looking for a sole MYC rearrangement. So FISH would be done to look for MYC, IGH, BCL2 and BCL6, and if the MYC rearrangement is the sole abnormality, a diagnosis of Burkitt lymphoma is made. Moving on then to the high-grade B-cell lymphomas. So in the 2016 classification, there was a subgroup that was particularly defined as the high-grade B-cell lymphomas with a MYC and BCL2 or a BCL6 rearrangement as well or instead of. This has been refined in the 22 classification, and so this now only describes a specific entity with MYC and BCL2 rearrangements. And so this is from the 5th revised edition published in Leukemia last year, essentially describing this so that patients with high-grade B-cell lymphoma with a sole MYC rearrangement are Burkitt's lymphoma. Those patients with high-grade morphology with a MYC rearrangement that also have a BCL2 rearrangement, they are a specific entity, the diffuse large B-cell lymphoma high-grade B-cell lymphoma with MYC and BCL2 rearrangements, and then the vast majority of other patients fall in either the diffuse large B-cell group or the high-grade B-cell group, which essentially are treated in the same way. And this is a schema that maybe shows this slightly more clearly in terms of Burkitt's lymphoma with MYC rearrangement. And then the high-grade and large B-cell lymphomas, the discrete entity with the MYC and BCL2 rearrangements, but indicating that all other patients essentially fall into the high-grade B-cell lymphoma stroke DLBCL group. So why the MYC and BCL2 rearrangement group has particularly been pulled out as a group within the high-grade lymphoma is that these are a homogeneous entity. They exclusively has a germinal-centered gene expression profile. They have a very close pathogenic relationship to follicular lymphoma, and their gene expression signature does overlap Burkitt lymphoma, but is separate from this. And by gene expression profile, there are two entities, either molecular high grade that was published by the UK group, or the double hit signature, which was published by the Canadian group, but both of which overlap with this MYC and BCL2 rearrangement group. And this is regarded as a discrete entity and a double hit lymphoma. In contrast, the high-grade lymphoma with the MYC and BCL6 rearrangements are more diverse. They have variable gene expression, variable mutations, and variable outcome. And therefore, this group is no longer regarded as a double-hit lymphoma as such. And as I say, is regarded within the high-grade or diffuse large B-cell lymphoma group. So just the important thing in terms of doing FISH on the high-grade lymphomas is, as I said before, a FISH panel of MYC, IGH, BCL2 and BCL6. And if there's a MYC rearrangement plus a BCL2 rearrangement, this is a discrete entity called the DLBCL high-grade MYC BCL2 group. Just one thing to note in terms of the double hit lymphomas is this paper from the Lunenburg group back in 2019 that looked at the MYC translocation partner, and what does seem to be important in the MYC BCL2 group is the translocation partner, whether this is immunoglobulin or non-immunoglobulin. And as you can see from this graph here, the green line, that if the translocation partner is immunoglobulin, either heavy or light chain, then the prognosis is particularly poor, but non-IG translocation partners do not carry such a poor prognosis. And this is important in terms of considering treatment for double hit lymphomas, although it should be said that there are only small patient numbers in this particular cohort. So just one final entity in terms of large B-cell lymphoma, so we've talked about DLBCL, the double hit lymphomas and Burkitt's lymphoma, is also the lymphoma of the immune privileged sites. So this includes primary large B-cell lymphoma of the CNS, of the vitreoretina and of the testes. And the important thing with this is the immunophenotype in terms of them being generally activated B-cell type. They're generally EBV negative, and they do commonly have MYD88 and 79B mutations and show a particular genomic signature which overlaps with MYD88, MCD, or C5. And these patients are treated in particular way in terms of the immune privileged site. So this is either specific directed therapy for the CNS or CNS prophylactic treatment because of the risk of CNS relapse. So this is just a diagram showing the sort of relationship between the large B-cell entities in the 4th edition and in the 5th edition of the WHO classification. And this is essentially showing that now primary DLBCL of the CNS is actually defined as an immune deficiency lymphoma. The same with DLBCL that affects the testes and the vitreoretina. This should also be called a large B-cell lymphoma of an immune privileged site. Otherwise, DLBCL and high-grade lymphoma is defined as we've already discussed. The only other thing to point out is there was a previous entity of B-cell lymphoma unclassifiable with features intermediate between DLBCL and classical Hodgkin's. And this is now really divided up according to the localization of the disease. So if the disease is in the mediastinum with both B-cell and Hodgkin's features, then this is called a mediastinal gray zone lymphoma, whereas all other B-cell lymphomas with features intermediate between the two entities are called diffuse large B-cell lymphoma. Follicular lymphoma, what's changed in the new classification is this is now termed classical follicular lymphoma rather than common type. But essentially, this is still described in the same way in terms of follicular growth pattern composed of centrocytes and centroblasts, with the vast majority of patients having a detectable 14-18 translocation. Histological pathological grading is no longer required. I think this is really because of the subjectivity of this, but it's well known within follicular lymphoma that there's a heterogeneous genomic landscape between patients and even within individual patients in different locations of the disease, with evidence of subclones. And there clearly are clusters of mutations in follicular lymphoma in the same way as there are in diffuse large B-cell lymphoma, with one group showing a high burden of aberrant somatic hypermutation, another group with high STAT6 and CREB-BP with low somatic hypermutation, and then sort of common follicular lymphoma, which has absence of features of other subtypes, but enriched for KMT2D. In terms of prognostic significance, this is still being investigated, and currently patients aren't treated differently according to these different mutations. Mantle cell lymphoma, this in the new classification is similar to previously, with the 11-14 translocation in the vast majority of patients, with very occasionally kappa or lambda as the cyclin D1 translocation partner. I think the important thing to say is that there can be cryptic rearrangements if the cyclin D1 is positive on histochemistry but no rearrangement, and it is important to look for other rearrangements in terms of cyclin D2, cyclin D3 and cyclin E. In terms of prognostic markers for mantle cell lymphoma, I think it's well described now that the pleomorphic or blastoid morphology is prognostic in terms of a higher risk. This also applies to if there's a high Ki67 proliferation index. And what is important is P53 expression and TP53 mutation. And this should now routinely be carried out on patients diagnosed with mantle cell lymphoma, as this does have prognostic significance and also therapeutic significance in terms of managing these patients, as in treatment options for these patients have increased in terms of the BTK inhibitors and CAR T-cell therapy. There is an entity, non-nodal mantle cell lymphoma, tends to have less CD5 expression, less Ki67, and less genetic complexity, and this is a more indolent disease. Just briefly to talk about lymphoplasmacytic lymphoma, there's two subtypes, and these molecular subsets are based on the presence or absence of MYD88. So the vast majority of patients have the MYD88 mutation, and this helps differentiate from nodal and extranodal marginal zone lymphoma from myeloma. And there's also CXCR4 mutations, which occur in up to 40% of patients, and these are associated with a shorter time to treatment and resistant to ibrutinib. So it's important to detect these mutations in terms of patient management. There's also a non-Waldenstrom's type, LPL, which represents about 5% of patients, and these patients tend to have an IgG or IgA monoclonal protein. Just talking about extranodal marginal zone lymphomas briefly, I'm not going to go into this in any detail, but there are associated bacterial infections related to certain types of extranodal marginal zone lymphoma, and also certain mutations that activate certain signaling or pathways that are important in the disease pathogenesis and prognosis. So I think what's becoming increasingly important in both high-grade and low-grade B-cell lymphomas is the presence of mutations, and therefore the importance of lymphoid sequencing. So this is an example of a pan-hemonc panel that we use in HMDS, but many hematological laboratories have similar targeted panels now, looking at a large number of genes in both myeloid and lymphoid malignancies. And this is our virtual panel, targeted panel for lymphoid malignancies, which really covers all the common mutations that are seen in B-cell lymphoid malignancies and that have both therapeutic and prognostic significance. So this can now be applied to either liquid biopsies or FFPE biopsies in terms of both bone marrow and nodal biopsies. So we now routinely use this in terms of aiding diagnosis and assisting prognosis and therapeutic treatments for patients. T-cell lymphomas, It's acknowledged in the revised WHO classification that this can still be quite challenging. It's not as well defined as B-cell lymphomas. There are many pitfalls, and it is still difficult to differentiate reactive T cells in the context of infection or maybe an autoimmune reaction from malignant processes. And undoubtedly within T-cell lymphomas, maybe even more than B-cell lymphomas, we need this integrated approach of the clinical, morphological, immunophenotypic features as well as clonality. And mutational profiles, although not so well defined, are becoming more defined. It can definitely help in more complex cases. So things like ROA, TEC2 support a malignant diagnosis, although aren't specific to one subtype. The clonality testing is important in diagnosing T-cell lymphoma. One is looking for a clonal pattern as opposed to a polyclonal pattern by now like this. But I think it's important to say that clonality in itself does not prove the presence of a malignant process, but a polyclonal pattern indicates it's less likely to be a malignant process. So I think this is helpful in terms of the diagnostic algorithm, although it shouldn't be used solely to diagnose a malignant process and needs to be considered in combination with the morphological and immunophenotypic features. Just talking about some of the commonest T-cell lymphomas, so anaplastic lymphoma, this is a discrete entity with strong expression of CD30 and generally defective expression of other T-cell markers. And there are 3 entities, and it's important to understand the difference between these. As primary cutaneous, ALCL has a very good outcome. There's ALK positive and ALK negative. ALCL with ALK negative associated with TP63 rearrangements, loss of TP53, and generally a poorer outcome. And breast implant associated ALCL, which is a discrete entity that needs consideration, because with resection, then this patient shouldn't require further treatment. Nodal T follicular helper cell lymphomas are very well described in the new 5th edition of the WHO, and looks particularly at the phenotype and gene expression signatures of these T follicular helper cells. And we use markers such as PD1, ICOS, CXCL13, CD10, and BCL6 to identify the T follicular helper phenotype. And this is defined as 2 of these markers plus CD4. And there's really now 3 entities that are clearly described: the nodal TF helper cell lymphoma, the angioimmunoblastic type. And this has a sort of stepwise acquisition of somatic changes. So TEC2 and DMT3A mutations occur early in the hemopoietic stem cells, and then ROA and IDH2 mutations are present in the neoplastic T follicular helper cells, which help us make the diagnosis of angioimmunoblastic T-cell lymphomas. And then there are other nodal TFH cell lymphomas which have slightly different morphological profile, either follicular type or NOS, but they have a similar marker expression and mutational profile to angioimmunoblastic T-cell lymphoma. So this is a typical example of angioimmunoblastic T-cell lymphoma with a pleomorphic population of T cells. There's commonly vascular proliferation, increased plasma cells, reduction or atrophy of the B-cell follicles, but with FBC networks that proliferate. And what we're mainly looking for in these sort of cases is at least 2 follicular helper markers present on the neoplastic cells with CD4 expression, and often there's an EBV positive B-cell component to angioimmunoblastic T-cell lymphoma. And this is just showing the mutational status, as I was just talking about, in terms of the presence of TEC2 and the DMT3A mutations, and also the acquisition of the ROA and ADH2 mutations. And ROA mutations are commonly seen in about 70% of angioimmunoblastic T-cell lymphomas, so do help with the diagnosis, as the morphology of these can be quite difficult to define, sometimes as angioimmunoblastic. So in summary, integrated diagnostics in lymphoma, we use a large number of diagnostic techniques within the laboratory to form an integrated diagnostic report. And this is then used for MDT discussion, so involving pathologists, clinical scientists, bioinformaticians, clinical geneticists, and also with the specialist clinicians, to ensure that we have an individualized patient report that allows individualized patient management. In terms of the future of integrated diagnostics, I think it's increasingly likely that we will use more lymphoid sequencing, and this will influence management in terms of both classifying patients, identifying certain mutations, for example, ROA in angioimmunoblastic lymphoma, which helps us to make the diagnosis, but also in terms of prognostic significance, for example, TP53 in mantle cell lymphoma, which will allow us to tailor the treatment for a specific patient. I think it's highly likely that the application of liquid biopsy assessment in terms of ctDNA will be used more in lymphoma and will allow dynamic risk assessment. So I think ctDNA will be useful in the future in terms of classifying patients, as illustrated here, for example, in diffuse large B-cell lymphoma into the different genetic subtypes, but also will allow non-invasive genotyping for patients where biopsy site isn't accessible, but ctDNA will allow us to diagnose the patients. ctDNA, I think, will also be used in terms of dynamic risk stratification, looking at ctDNA burden at diagnosis, but also how this declines with treatment, and will also allow us to identify more easily the development of subclones or more quickly MRD. So lymphoma diagnostics has changed significantly over the last few years. This has been acknowledged by the WHO classification in terms of the integration of more molecular techniques and molecular results. And I think it will continue to develop in terms of looking at ctDNA and more established sequencing in routine diagnostics. Thank you very much for listening.
Hello, I'm Wendy Osborne and I'm a consultant haematologist from Newcastle in the UK. And I've got this important question to discuss about how we should manage diffuse large B-cell lymphoma in the first-line setting. And it's really important because it's the commonest non-Hodgkin lymphoma. And although for many patients it is curable, it's a disaster when a patient relapses for some of our patients because the subsequent treatments are often toxic and the responses aren't as good as they can be in a first-line setting. When we think about diffuse large B-cell lymphoma, it's one of the large B-cell lymphomas. And as you can see here, it's not just one disease. It's the commonest one, but large B-cell lymphomas include other lymphomas such as high-grade B-cell lymphoma, NOS, and double-hit lymphomas. So they're treated in a similar way, and I will come and talk about those, but generally we tend to think of large B-cell lymphomas and diffuse large B-cell lymphomas as similar. Now, before we even start to think about treatment, it's important that we stage our patient with a PET scan. We do often do a prognostic score, so an IPI score, and I remember apples, the mnemonic, with only 1P. We must know their cardiac function is adequate because we often give anthracyclines, that they have a negative viral screen, and obviously considering fertility preservation. One of the most important things is to make sure they've met our specialist nurses who certainly run the show where I work, really important for our patients, have a specialist nurse contact, and our MDT discussions. And then I think that there are 7 important first-line treatment decisions, and I'm going to go through these 7 questions. And the first one is if we're thinking about a patient with early-stage disease. So early-stage disease is actually quite common, almost a quarter of patients, and we tend to think about stage 1 or 2 disease that's encompassable with radiotherapy as early stage. And what's important about early stage studies is to look at what the inclusion criteria are to make sure that you transfer that to your patient in clinic. Because, for example, many studies excluded patients with bulky disease because these were considered higher risk. We can also do a stage modified IPI, and this includes older patients, poorer performance status, stage 2 instead of stage 1, and a high LDH as adverse risk. And this is important because it's prognostic, but it also, again, allows us to ensure that we are treating the right patients with the right risk-adapted approach. But for many years, we've used a combined modality approach using 3 cycles of chemo and radiotherapy. And this was because it was shown to be superior compared to chemotherapy alone in a SWOG study done many years ago. This was in a pre-rituximab era, so a long time ago, and patients actually got 8 cycles of CHOP. But when these data were presented, many clinicians moved to this combined modality approach. It is important to note that with further follow-up, some of this benefit has been lost. And whether this is because the patient's got less cycles of chemo or whether because it's a slightly different biology of disease isn't clear. But I think it's important to remember this when we think about some higher risk patients with early stage disease, and if we really do want to reduce their treatment. The next question was, do we really need to give radiotherapy? Could we give just 4 cycles of chemotherapy instead of a combined modality approach? Now, the FLIER study only looked at very good risk patients with stage modified IPI of 0, so not a common group in our MDT. But if a patient was very good risk, they were randomized to 4 R-CHOPs and 2 additional rituximab compared to 6 R-CHOPs. And what this showed was that it was non-inferior. So if you have a patient in your MDT with a stage modified IPI of 0, you can give them just 4 R-CHOPs. I tend to not give the 2 additional rituximabs. I'm not sure that we need to gain from that. But I think that this didn't hugely change practice because these patient groups are rare. The data that changed practice, certainly for me, was this PET-guided approach, which has been adopted in British Columbia for a while. And we've got several data sets now showing a similar outcome, that for patients with limited stage, non-bulk, so in this study, less than 10 centimeters, I consider bulk as 7.5 centimeters, and so do other studies. The patients were given R-CHOP 3 cycles and then a PET scan. And if that PET was negative, then they had a 4th cycle of R-CHOP. And if it was PET positive, they had radiotherapy. Now, this was important because it included a more real-world population that we see, so higher risk patients than in the FLIER study. And almost everybody had a stage-modified IPI of 0 to 2. So they didn't really include any patients with stage-modified IPI 3 to 4. Half of the patients did have extranodal involvement. Now, I think that this is difficult because there are so many different extranodal sites that there are too few numbers in each of the studies you look at to truly say that one site can be managed with this approach. And some of the studies considered tonsillar disease to be extranodal, which I consider as a good risk nodal site. But what they showed is that if patients were interim PET after 3 cycles of R-CHOP negative and had a 4th R-CHOP, the outcomes were very good. The patients, the PET positive curve, I thought was a bit disappointing. And so if my patients are PET positive following this approach, I do complete the 6 cycles of R-CHOP and give radiotherapy. But this and other studies have allowed us to give a PET-guided approach. Now, as I've said, the data are mixed about extranodal sites. There are some retrospective data suggesting that these patients do less well. And if you remember that follow-up from that initial SWOG study showing those later relapses overall, I tend to be more cautious with these patients and treat them as I do advanced stage disease with 6 cycles of chemotherapy. But it is discussed on an individual basis, and some centers would treat these patients as they would nodal early stage disease. We do have some data about specific extranodal sites, and I think that most of us would certainly treat testicular and breast with 6 cycles of chemotherapy. And I tend to do the same with gastric and bone. There's a little bit of data about H. pylori eradication, but most centers would give chemotherapy with R-CHOP, which would be my approach. I think if you're going to do the H. pylori eradication approach, you do need to review your patients carefully and do regular endoscopies. Then the next question is, if you've given your patient 6 cycles, do you need to give radiotherapy consolidation as well? And again, the data are mixed. And I think that's a risk-benefit approach in terms of what that toxicity of radiotherapy would be to consolidate when we don't have clear data. So when I'm in the MDT, the first question I want to know is, are they favourable risk? So do they fit the criteria of most of these studies? So are they not bulky? Have they got a stage modified IPI of 0 to 2, no extranodal disease, and can they follow up? Can they tolerate full dose R-CHOP? Then the next question is to balance up which is going to be of more toxicity to the patient. Because for some patients, that fourth cycle of R-CHOP may be more toxic than giving them radiotherapy to that site. And that's going to be disease factors, site of disease, patient factors, for example, age. And we will then go through and decide which approach. So this is our flow diagram. So the early stage favourable are on the left, individual patient risk, and then we either follow a PET adapted approach with a PET scan after 3 cycles of R-CHOP, moving to 4 if they are in an CMR, or we would give them planned combined modality treatment. And if they've got risk factors, they fall into our early stage intermediate group, where we tend to treat them with 6 cycles of chemotherapy. So can we improve on R-CHOP 21 for our advanced stage patients? And for many years, there have been many studies looking to try and improve the outcome of our previous standard of care. And the UK, led by Andy Davis, looked at the addition of bortezomib to R-CHOP in the Remodel B study. And in this study, the primary endpoint looking at outcome at 3 years showed that there wasn't a benefit. It did show that central real-time gene expression could be done to determine cell of origin, and it did identify this high-risk group that had so-called molecular high-grade phenotype, which had an inferior outcome. But just last year at ASH, he presented the 5-year follow-up data, which showed that the patients in the ABC subgroup who had the addition of bortezomib had a 15% improvement in PFS, and that was up to 26% in the molecular high-grade group. And there was also a translated overall survival in the ABC group. And so this was exciting, but bortezomib doesn't have a license in a first-line setting. And this was an academic study, so no pharmaceutical company behind it to try and get license. And it was also published at the same time as the Polaric study data came through, and this has led to a change in practice. So the Polaric study randomized patients to either R-CHOP or Polar R-CHOP, and it was a blinded placebo-controlled study for patients with an IPI of 2 to 5. And it showed that there was an improvement in progression-free survival at 6.5% at 2 years. Now, interestingly, there's been no overall survival benefit, but it was these data showing that there were more progressions in the patients who didn't have the polatuzumab. And therefore, when looking at the both cost of these subsequent therapies and also impact on patients, NICE has now approved this in the UK for patients IPI 2 to 5. There's been a lot of discussion about the subgroup analysis. You can see here that actually you could argue that maybe you shouldn't use it for women because there's only benefit in men. Maybe you shouldn't use it in younger people or in patients with an IPI of 2. However, when this was discussed by NICE, this is underpowered, and therefore these subgroups weren't powered enough to say that it's no benefit in certain subgroups, and therefore it's used across subgroups. As I've said, there is no overall survival difference between the arms. The safety profile is similar. There's more febrile neutropenia and diarrhea in the polatuzumab arm. With additional follow-up at 3 years, the PFS benefit is 7.7% and no OS benefit. So can we improve on R-CHOP 21? I think I've shown you 2 studies there which have, and the Polaric study is now commissioned. Well, it's NICE approved that we can use this for IPI 2 to 5. So should we ever intensify first-line therapy? Should we be using DAR-EPOC or Codox-M-IVAC or doing autologous stem cell transplants for patients? And again, there's been a lot of discussion over the years. But a randomized study of all comers diffuse large B-cell lymphoma, large cell lymphoma, showed that patients were randomized to R-CHOP and DR-EPOCH, there was no difference in outcome. Looking at high IPI patients, again, there was some initial encouraging data from the German group using R-CHOEP14, but in a randomized study with that mega R-CHOEP14 plus autologous stem cell transplant, there was no superiority. The UK CODOX-M IVAC trial, high-risk group of patients with a good outcome for these high-risk patients, but it wasn't without toxicity, and there were 5 treatment-related deaths, all in patients with a performance status of 3 and over the age of 50. So some centres would use this CODOX-M IVAC approach for high IPI. Personally, because of the toxicity associated and not clear randomised benefit, I treat mine as I would any other patient with diffuse large B. There's no clear benefit of an upfront auto, and I don't think that can be done outside of a clinical trial. And there's a lot of debate, and my practice for double-hit lymphoma has changed over the years. Initially, I think there was some reporting bias suggesting there was benefit of either consolidating or giving more intensive treatment. But as more data are being published, I think that there's more variation in that data. And again, more recent data from Flatiron series, which has all the caveats of retrospective data, there didn't appear to be a benefit from patients who got DAR-EPOCH. And I think it is clear that there's more toxicity with DAR-EPOCH. So I do tend to just manage my patients as I would any other patient. So polar-R-CHOP or R-CHOP. I think if some centres do intensify and that the data aren't clear, so that's not the wrong thing to do. But I think that if you are, you do need to know what the immunoglobulin partner gene is, or if MYC has an immunoglobulin partner gene, because these data suggest it's only this group of double hit patients that are associated with a poor prognosis. It may be that we will learn which patients we should intensify. And it may be that a PET-adapted approach, as we do for Hodgkin lymphoma, could be the way in which we can select patients, maybe this in combination in the future with circulating DNA. But these data from the French group intensified patients who had interim PET positivity. And you can see in the middle, those patients who were PET4 positive went on to salvage therapy or high dose therapy. If they were PET2 positive and PET4 negative, then they got methotrexate and a beam auto. Now, this wasn't a randomized study. It was only randomized to look at the antibody backbone. So either rituximab or blinatumomab. It wasn't randomized to look at the approach. So I think that these are early data, so not to inform practice change yet, but I think intriguing data. So can we improve on R-CHOP21? I think we can. Should we intensify? There's a lot of discussion in the data. As yet, personally, I don't intensify any of my patients up front. But that may change in the future if we get more convincing data. Now, I've talked about the role of radiotherapy in early stage disease. What about the role of radiotherapy in advanced stage disease? And again, I think our practice has changed. It used to be that for all patients who had bulky disease, so considered as more than 7.5 centimeters, we would give them 6 cycles of R-CHOP, which was the standard at that point, and then consolidate them with radiotherapy. And that was from data showing benefit in the Unfolded study and the Recover 60 study. However, since we have now had the ability to use PET scanning and really understanding if residual masses are actually disease, it's allowed us to question whether we really need to do that. And actually, the Optimal 60 study suggested that if patients are PET negative, you don't need to give radiotherapy. And another meta-analysis suggesting that routine radiotherapy to bulk is not necessary. Now, again, looking at retrospective data from British Columbia, they've trusted the PET for a long time. And you can see here that if patients are PET negative with bulky disease, then they do just as well as if they haven't got bulk. And the outcomes of the top graph show that the non-bulky disease do just as well as the bulky disease. So from their retrospective data, if a patient, despite bulk, reaches PET negativity, we don't need to consolidate. However, I think that this bottom graph is also really important. because it shows that if patients have PET positivity at the end of treatment, not just to do with bulk, any PET positivity, and you give them radiotherapy, you can bring up that survival curve. And so now I don't routinely give radiotherapy to bulk. I look at that PET scan. Now, it is discussed on an individual basis. We don't have randomized data. We know that for some patients, the site of disease may be associated with limited toxicity if we did consolidate them. For the majority of patients, we would use a PET-guided consolidation approach. However, if they are PET positive at the end of their first-line polar R-CHOP, we will be quite aggressive at trying to give them radiotherapy, even if it's in more than one site. And I think that some patients do obtain a durable response, as shown from this data from British Columbia. So, 4 important questions. I think that the next 3, I think there's still some big discussion in the data. And one is how we should treat older patients. Now, older patients could be a whole discussion in itself. And I think that the difficulty with managing older patients is it's such a heterogeneous group. We have some patients who are 85 and still cycle 10 miles a day, and we have other patients with a performance status of 3 with multiple comorbidities. And so therefore, we cannot really, it's very difficult to compare age groups because of the heterogeneity between them. It's also difficult because although we have many functional assessments available, they don't clearly guide us to selecting the optimal treatment for the patient. They also take time, and because there's not that clear decision-making tool in terms of if a patient has a STIRS rating score of X, we should definitely give Y, and that's evidence-based. I think is in the solid tumor community, there is more data to allow that comparison. I think that therefore we don't routinely do this. We're getting better, but we don't routinely do this, and it makes it difficult to interpret across studies. I think that if we have an older patient, we do tend to treat them with R-CHOP or R-mini-CHOP. If a patient is fit enough for full dose R-CHOP and their performance status is adequate for that, and their IPI is 2 to 5, then I would be happy to give them polar R-CHOP. However, I don't give polar R-mini-CHOP because the data aren't there yet to show that there's a benefit by giving patients polar R-mini-CHOP. So for us, usually we don't have strict age cutoffs, but for the most of our patients over 80, if we assess their functional fitness and comorbidities, usually most of our patients would get R-mini-CHOP. If they're particularly fit, and we think that they would tolerate full dose R-CHOP, then we would consider polar R-CHOP. If they don't have a good cardiac function, we'll give them R-CGVP, and that's from Paul Field's UK data. And it's really important to consider bone protection, which I will come on and mention, and also GCSF prophylaxis. The French study group have published widely about steroid prephase, so has the Germans. And I think that if a patient has a poor performance status, then it's really helpful to give a steroid prephase. It reduces that morbidity and mortality in that first cycle and allows us to assess really how fit our patient is. It's really been over the last 5 years or so that we've been wanting to give bone prophylaxis. And this is from some data published about how high the actual incidence of fracture is for our patients, particularly our older patients who have other risk factors. And so therefore now if our patients, because with our polar R-CHOP or R-CHOP treatments, they are getting significant doses of steroids, we now give them prophylaxis. And that can be either with weekly bisphosphonate, or some centres use a one-off dose of zolendronate, obviously making sure that they're happy with their dental assessment because of risk of osteonecrosis of the jaw. Now, as I showed you in that first diagram, primary mediastinal lymphoma is a subtype of one of the large cell lymphomas, but it is different. It's different because of its biology. So most cases express CD30. It's different in who it affects, so it's usually young women and sort of median age 35. And because it's different, we do treat it in a different way. I think it's important to recognize there's a lot of thrombotic complications. And so I would always give low molecular weight heparin in the first cycle at least because of risk of thrombosis. Patients often present with SVCO obstruction and they can have pleural or pericardial effusions. And the big question was, do we need to consolidate these patients with radiotherapy? And it was always a really important question because of where the site of disease is, because these young women, we did not want to give huge mediastinal radiotherapy consolidation because of the late effects and the cardiac effect on these young women. And therefore, I think it's been important that just in the summer, data were published and presented from the ILSG 37 study. So in this study, patients were given R chemo, and I will talk about the R chemo backbone in just a moment. But if patients obtained PET negativity after 6 cycles of R chemo, they were randomized to radiotherapy or not. And what these studies showed is that if patients obtain PET negativity, the outcomes are good. So you can see that fantastic progression-free survival, and that didn't matter if they had radiotherapy or not. So I think it's now standard that if our patients have their R chemo and are PET negative, we do not need to consolidate them with radiotherapy. If a patient relapses after primary mediastinal lymphoma, they are often more difficult to get into a complete remission than other large cell lymphomas. So we worry about the PET positive patients. In this study, patients who were Doval 4 or Doval 5 all had radiotherapy. There's still debate about the optimal management for these patients. I think it's fair to say that we would consider Doval 5 all as having disease. We would give them radiotherapy, but unfortunately, many of them will go on and progress. Doval 4 is a heterogeneous group. Some of these will just be Doval 4. They may be false positives. They may be able to be observed with a close follow-up scan, no longer than 6 weeks, I would say. Some may be truly diseased. So I think that this group needs to be discussed individually in the MDT. If there's any anatomical abnormality as well, I would be keen to give radiotherapy because of that risk of if they go on and relapse. So Doval 4 are a heterogeneous group. There were also data about which R chemo regimen was used. Now, it's important to note that this wasn't randomized data, so physicians could choose their R chemo backbone. But it's fair to say that R-CHOP 21 appeared to have an inferior outcome compared to R-CHOP 14 and DAR-EPOC. So I would now use R-CHOP 14 for my patients with primary mediastinal lymphoma. So giving it every 2 weeks. I would give them 6 cycles. I would do a sensitive 6-week PET scan. And if they were Doval score 1 to 3, I would not give them any radiotherapy. And I would discuss all Doval 4s and 5s in the MDT. And then finally, CNS prophylaxis, who and how? And again, a big controversy in this area. I think it's fair to say that we know who. I think we know that patients who are high CNS IPI, so that includes the IPI plus renal and adrenal disease, have a high relapse risk. So you can see that if they've got an IPI of CNS IPI of 6, they have a 32.5% 2-year rate of relapse. So that is really high. And we also know that there are other high-risk sites. The CNS Good Practice paper led by Pam Mackay and Kate Sinarski is really helpful. And this is, having looked at all of the data, summarizes that CNS prophylaxis should be offered to the high IPI sites, 3 or more extranodal sites, and these high-risk anatomical sites. Testicular lymphoma patients are particularly at risk, and they should be considered for IT as well as systemic prophylaxis following other data showing that this may be of benefit. There has been a change in which approach to CNS prophylaxis we use. And previously, 10 years ago, having given many ITs, moving now over IV method to IV methotrexate. It used to be intercalated, but data has shown that this causes delay in the primary proven R-CHOP chemotherapy. And so therefore, if you're going to give the IV methotrexate, it should be given at the end of the treatment so that there's no delays caused. There's been a lot of retrospective data suggesting that it's ineffective. I think we have to be quite cautious with the retrospective data because it's often underpowered. And because if a patient relapses in their CNS, it is devastating and the outcomes are really poor. So it is a balance in deciding whether we give this treatment, which may or may not be effective, when we don't have clear data, which is often underpowered as well. So I think that since some of these data have been presented, there's been a change within the UK that most patients have a lower threshold to not give the methotrexate prophylaxis. And now I would tend to give it for CNS IPI 5 and 6 only. And if my patients have any comorbidities or are older, therefore you worry about their renal function, then I do worry about the CNS prophylaxis, and sometimes I don't give it. I push harder for the testicular patients. And I think if I am going to give it, I give IV methotrexate, and I do it at the end of their chemotherapy, so I'm not causing any delay. So these are 7 important questions. The MDT is essential for many of these questions, partly because, as you've seen, we have discussed radiotherapy a lot. So we need to make sure our clinical oncologists are in the room to give their advice, to give their opinion about the risk versus benefit of radiotherapy to that particular site of disease. So if I'm going through these 7 important questions, just to summarize, early stage disease, we have to balance up that risk of a 4th cycle of R-CHOP versus radiotherapy using a combined 3 R-CHOP and radiotherapy approach. And I'm always cautious to exclude higher risk patients, so bulky disease, not able to tolerate full dose R-CHOP, for example, and I tend to give them the full 6 cycles. We can improve on R-CHOP 21, and that's been shown in the Remodel B study with bortezomib, and the polatuzumab has shown a progression-free survival advantage, but no overall survival advantage. I personally don't interpret the data that there is a benefit from intensifying at first line for high-risk patients. I don't routinely give radiotherapy to bulky disease, but I'm aware there's no randomized data for that. So there may be the occasional patient with bulky disease where that is the main site of the disease where we may consolidate. And this is individual patient review in the MDT, which is essential. For older patients, tend to give R-mini CHOP or RCGVP. I do give pre-phase steroids if they've got a poor performance status, and bone protection is important for many of our patients, but particularly this older subgroup. Primary mediastinal lymphoma, R-CHOP 14 is my approach now. I think DAR-EPOCH is reasonable. I find it more difficult to deliver and it is more toxic. And if they're PET negative, you don't need to give them radiotherapy. And there's a lot of controversy about CNS prophylaxis. Maybe we'll have more clear data in the future, but this is definitely a risk-benefit decision for all of our patients. And the most important message is obviously our clinical nurse specialists are essential. Our patients going through really tough treatment in a first-line setting, and if they have good contact and able to contact their nurse specialist who reviews them through chemo, then that is essential. Thank you very much.
Welcome. I'm Andy Davis from the University of Southampton, and the topic is relapsed and refractory diffuse large B-cell lymphoma. So I have a number of conflicts of interest that I wish to share with you. I'm very much involved in the development of new drugs, and so have a lot of interactions with the pharmaceutical industry. Now, you would have heard about diffuse large B-cell lymphoma in the frontline setting, and that in clinical trials that we can expect probably about 80% of patients to be alive 2 to 3 years after diagnosis. But in the real world population, unfortunately, very many of our patients with diffuse large B-cell lymphoma are failed by conventional therapies. And in fact, probably overall survival at 2 to 3 years is probably something in the order of about 60%. And that means that there are lots of patients that are being failed by our current approaches to diffuse large B-cell lymphoma. And so lots of room for improvement. Now, we're quite good at predicting which patients are going to do well with diffuse large B-cell lymphoma and perhaps which patients are going to do less well. And the simple clinical parameter of the IPI, the International Prognostic Index, based upon 5 clinical variables, really can pull out those best risk patients where expectation of success is very high, compared with those patients who have multiple risk factors, maybe 3, 4, or 5 variables associated with a poorer prognosis, where we know the outcomes are less good and expectations of overall survival are somewhere in the order of just 50%. And we can layer on top of that information about the biology of the lymphoma just on top to add additional information about prognosis. We recognize that those with an ABC phenotype are much more likely to relapse than those patients with a GCB phenotype. And those patients with double hit lymphoma, so translocations of MYC and BCL2, are probably going to do less well than those patients without translocations, and also those patients who have overexpression of MYC and BCL2 proteins in the absence of translocations are also similarly likely to do less well. So I show you this data so to just read to say that we can predict quite well who are our highest risk patients for relapse. And we recognize that with conventional R-CHOP chemotherapy, we're going to cure about 60 to 70% of patients. But really, we see about 15% of patients are refractory to therapy with R-CHOP chemotherapy. That means that they really show a very short-lived response if there is any response at all. There are a group of patients who have a relapse after having achieved a complete response. That's probably about 20 to 25% of patients. For those patients, unfortunately, who do have relapsed or refractory diffuse large B-cell lymphoma, the expectations of success, unfortunately, is limited. And with traditional therapies, up until where we've seen these paradigm shifts in treatment more recently, the median overall survival has been somewhere in the order of about 6 months, with only about 20% of patients alive at 2 years. So there's been really a lot of scope to try and improve outcomes for these patients. Now, why do patients have relapse? Why do patients have refractory disease? Well, dissecting the biology as to why that happens is a key priority for us. We recognize that there are some acquisition of new mutations that develop, such as mutations in P53 that are associated with relapse disease. But actually, there's a lot of work still to be done in terms of trying to understand the biology of relapse and why one patient's tumor may be intrinsically refractory compared with another. Now, let's think about the treatment approaches to relapse and refractory diffuse large B-cell lymphoma. There has been a paradigm shift in our treatment approaches over really the last year or so, and our algorithms for treatment have completely changed. So if a patient has relapsed or refractory disease, we recognize that the majority of patients will relapse or have refractory disease with less than 1 year from their initial therapy. That represents about 70 to 75% of patients. The other 20 to 25% of patients will be those patients who relapse over 1 year from therapy. And I think that all that we were doing previously up until 2022 has been turned on its head by the fact that second-line CAR T cells are available in very many territories for the treatment of disease at relapse. And I want to just show you some of the evidence base that's brought us to this paradigm shift in terms of treatment algorithms. So the first question we're going to ask is a little bit more of the traditional route. And this route is for those patients who relapse over 1 year from their initial frontline therapy. As I said, it's about 25% of patients. The first question we need to ask is this patient fit? Will this patient be eligible for high-dose chemotherapy and peripheral blood progenitor cell rescue? Now, we recognized for about 25 years that for those patients who do have relapse disease, the application of high-dose chemotherapy and peripheral blood progenitor cell rescue to consolidate a second remission of diffuse large B-cell lymphoma has a significant advantage over standard chemotherapy. And the so-called Palmer study, which was published in 1995 now, demonstrated that those patients who received conventional reinduction chemotherapy with DHAP compared with those patients who had reinduction therapy, and if they responded, went on to have high-dose chemotherapy and stem cell rescue, the patients with the high-dose chemotherapy did much better in terms of progression-free survival and overall survival. And so that's why for the last 25 years, we've been offering those patients who are fit enough to undergo high-dose chemotherapy, they've got good cardiac function, they've got good pulmonary function, they've got good kidneys, etc. So those patients who are fit without comorbidities, high-dose chemotherapy and stem cell rescue has been our mainstay of therapy. How do we get patients to high-dose chemotherapy? Well, we give patients reinduction chemotherapy to debulk them, demonstrate that they are sensitive to chemotherapy, and then consolidate that response with high-dose chemotherapy. And there are a number of different regimens that you will have heard about that are being used as reinduction treatment. And these are just different recipes of drugs that are non-cross resistant to R-CHOP chemotherapy with the hope of achieving benefit and remission, because we know we don't want to go on to give high-dose chemotherapy if we haven't demonstrated that the patient is already sensitive to chemotherapy at relapse. And so some of these regimens you would have heard of are DHAP, R-ICE, R-GDP, R-MIME, R-ESHAP, etc. And really there's very little evidence to demonstrate that there's any difference between any one of these regimens. This is a study called the CORAL study, which compared R-DHAP with R-ICE chemotherapy, and it demonstrated no difference in outcome. All of them are probably associated with response rates of about 60 to 70%. All of them are relatively well tolerated, although they are probably a little bit more toxic than conventional R-CHOP chemotherapy. And all of them are really good at mobilizing peripheral blood progenitor cells that we can use to support high-dose chemotherapy later. The GDP regimen, which is gemcitabine, cisplatin, and dexamethasone, was compared with R-DHAP in a study performed by the Canadian National Cancer Institute. And the advantage of GDP is that it can be given as an outpatient, and it showed no difference in outcome. And perhaps the quality of life for patients who had GDP was better than DHAP. And so for that reason, NICE recommends that GDP is a good option for patients with relapse and refractory disease. So GDP, DHAP, ICE, etc. I would say use a regimen that you feel comfortable and familiar with, and you recognize you can manage the toxicities. Now, we've tried to improve outcomes by using a different monoclonal antibody partnered with the chemotherapy backbone. In the Orchard study, instead of using rituximab, the anti-CD20 ofatumumab was examined in a direct head-to-head comparison with rituximab with a DHAP chemotherapy backbone. It showed no difference, and so this wasn't a way of improving outcomes. And I think what's really important is for us to recognize that if you respond and then you go on to have high-dose chemotherapy consolidation, what's really important in terms of the success of the program is really how long it's been for those patients from the initial diagnosis and from initial therapy. So from those patients who relapse more than 12 months from diagnosis, probably about 50% or so of patients will be event-free 2 to 3 years after the time of starting second-line chemotherapy. But for those patients who unfortunately have a refractory disease or relapse less than 12 months from diagnosis, unfortunately the success of this approach of reinduction chemotherapy followed by high-dose chemotherapy has been really disappointingly poor. And it's the event-free survival for these patients is less than 20% in the rituximab era. So that's really why we've seen a focus on this particularly high-risk group of patients who relapse within 1 year from the initial frontline chemotherapy. Now, A lot of people talk about doing high-dose chemotherapy only in patients who achieve a complete remission if they with their reinduction chemotherapy. I think there is certainly a role for patients who do achieve a very good response but aren't quite all the way there and may have some smaller areas of residual PET avidity. And there's a number of series of data that have suggested that there is benefit still to be had from consolidating those patients with high-dose chemotherapy. But this is a very individualized decision. So a partial response can be very many things. I think for patients who have small amount of residual disease after reinduction chemotherapy, this is a good approach. But for patients who have more burdensome disease, then going on to high-dose chemotherapy really isn't the right thing, because you really haven't demonstrated that these patients are refractory, are responding and cytoreducing with chemotherapy. There's also a role for high-dose chemotherapy in older patients. We've sort of traditionally looked at maybe in the mid-60s towards 70 being the upper limits of age for tolerability of high-dose chemotherapy, but that's changing. We're seeing more and more fitter 70-year-olds, and we're doing more and more high-dose chemotherapy procedures in patients over the age of 70. But this is really dependent upon patient selection, but they can have excellent outcome. I think what we really need to think about is the fact that their recovery, however, may be a little bit slower than younger patients, and we need to really tailor this as an individualized decision. But clinically, older patients, if they are fit enough, do benefit hugely from high-dose chemotherapy in the right circumstances. Now, the big paradigm shift. So for those patients who we know who relapse less than 1 year from their initial therapy, who we've already demonstrated are going to do less well and are the majority of patients with diffuse large B-cell lymphoma, CAR T cells are now available for this group of patients in very many territories. Now, I do recognize that there will be listeners where second-line CAR T cells are not yet available, and really we're still going down the more traditional approaches with reinduction chemotherapy. So let's talk now about the paradigm shift in second-line therapy with CAR T cell treatment. So, of course, you recognize that CAR T cell therapy involves the viral transfection of T cells derived from the patient with a chimeric antigen that is able to target CD19 on the surface of the malignant B cell and carries a co-stimulatory domain, which essentially causes activation of the T cells, which result in death of the malignant B cell. And there are 3 approved products, CAR T cell products. Depending upon where you live, maybe only 2 of these have been approved. Certainly for those of you in the UK, that's Axicaptogene and Tesogen that are approved. There are some differences in the manufacturing processes. There are some differences in the co-stimulatory molecule and the construct, but basically the products target CD19 on the surface of the malignant B cell. And the manufacturing process is a complex one, and there are many stumbling blocks potentially along the way as we take patients through a CAR T cell pathway. But essentially, patients are leukapheresed and T cells are collected. The T cells are enriched, they are activated during the manufacturing process, and then undergo a process of viral transduction. With successful viral transduction, the T cells are then expanded, they are formulated and cryopreserved, and they are shipped back to the CAR T cell center, where they are reinfused to the same patient once they've received some lymphodepleting chemotherapy. Now, that timeline for that process is very variable depending upon your territory and your proximity to manufacturing facilities, but probably can take 3 to 4 weeks. And during that 3 to 4 week period, we need to think about how we might manage the patient's disease, because we recognize with relapse and refractory diffuse large B-cell lymphoma, the kinetics of the disease can often be quite rapid. And we often give patients what we call bridging therapy, which is chemotherapy or radiotherapy in that interval between apheresis and reinfusion of the CAR T cell product, in order to help maintain them in a good fitness and hopefully to achieve a response in their disease. So the data that we initially had for CAR T-cell therapy was actually in the third line setting. So patients who'd previously failed 2 lines of therapy, many of them having failed high-dose chemotherapy and stem cell rescue. And with CAR T-cell therapy in the third line setting, about 75% of patients were responding, with probably up to 50 to 60% of patients achieving a complete remission. And we can see from the curve, whilst there are very many patients who unfortunately relapsed early after having had CAR T-cell therapy, that there begins to be a plateau after about 4 to 6 months, where patients, the rate of relapse reduces significantly. And now with long-term follow-up of that data, 5 years, in this group of patients with really difficult, highly refractory disease, about 40% of patients or 45% of patients are alive 5 years after having had CAR T-cell therapy. So in the third line setting, it's been really exciting and really important data, and really started to shift the dial in terms of how we approached relapsed and refractory DLBCL. Of course, CAR T-cell therapy comes with its own toxicities. We get cytokine release syndrome, which coincides with the maximal T-cell expansion and typically occurs sort of 2 to 7 days or so after reinfusion of the CAR T. We also see this this toxicity, this neurological toxicity called ICANS, which occurs a little bit later, probably with a median onset of about 5 days, which can present itself in a whole range of neurological symptoms such as aphasia, drowsiness, confusion, tremor, seizures, etc. And we've discovered, we've over the years of managing patients with CAR T-cell therapy, we've refined our strategies to recognize early these specific toxicities and how we might intervene and reverse these, which we can do with careful observation and fairly early intervention. So we recognize that these toxicities are quite specific to these T-cell engaging therapies. We also recognize that there are some long-term toxicities associated with CAR T-cell therapies. These are the fact that we can get cytopenias, and often patients need quite a lot of support with blood products or growth factors or prophylactic antibiotics. We see the long-term problem, the fact that these patients have B-cell aplasia with hypergammaglobulinemia and may require intravenous immunoglobulin replacement. Now, of course, given the success of CAR T-cell therapy in the third line setting, it was only natural to ask the question, given that patients with disease that relapse with less than 12 months since completion of initial therapy, really we should be looking at using CAR T-cell patients in that really high-risk group of patients who don't do well with conventional high-dose chemotherapy and stem cell rescue. So a number of studies were performed where CAR T-cells were directly compared in a one-to-one randomized fashion with the standard care of reinduction platinum-based chemotherapy followed by high-dose chemotherapy and stem cell rescue. ZUMA-7, I'm sure you have heard of. It was one of the studies that recruited 400 patients to receive either standard therapy or to receive CAR T-cell therapy. Now, in this study, the upper blue line represents the patients who received the axi-cell CAR T-cell experimental arm, and the red arm represents those patients who received standard of care. And you can see event-free survival at 2 years was just 16% for those patients with high-dose chemotherapy and stem cell rescue, absolutely in line with what we've observed in the prior data. But for those patients who received CAR T-cell therapy, event-free survival was some 40% at 2 years. So a sort of an outstanding win really for CAR T-cell therapy in the second line setting. And this worked for all age groups. So we saw that in older patients, they particularly benefited from this approach. And we saw benefit across a range of histologies and a range of risk factors for patients. Now, just this year, we've seen maturation of this data with longer follow-up. And with longer follow-up, we can see actually there's an overall survival advantage for giving CAR T-cell therapy over standard of care. And this improvement in overall survival came despite the fact that actually about 50% of the patients treated in the standard care arm who relapsed went on to get CAR T-cell therapy in the third line setting. So here we see that CAR T-cells in this high-risk group of patients is associated with a significant improvement in overall survival. And that's the reason there has been this paradigm shift in our treatment algorithm for those patients who are the most difficult in terms of disease control, who relapse less than 1 year from their initial completion of therapy. A second study used a different CAR T-cell construct called Lysocell. This is not yet available in the UK. It showed a similar result in terms of its primary endpoint of event-free survival when compared with standard of care chemotherapy, demonstrating a significant improvement in outcomes for those patients treated with CAR T-cell therapy. And again, the forest plot for this study just demonstrates that the patients across all clinical and biological risk groups all had a significant degree of benefit from therapy. This data is not yet mature enough in terms of demonstrating an overall survival advantage. However, there are significant challenges associated with delivery of CAR T-cell therapy in the second-line space. There are manufacturing challenges still, the kinetics of the disease, whilst patients wait 3 or 4 weeks for their CAR T cells to be manufactured and be delivered, and how we best control the disease in that time. Obviously, there are questions about tolerability of CAR T cell therapy. There are still geographical constraints, despite the fact the number of CAR T cell centers has significantly increased over the number of years. Many patients still live a long distance from a CAR T cell reinfusion center and are unwilling to make that journey. There are social and economic challenges, and really, we need to ensure equity of access by, for CAR T cell programs. And of course, there still remains a high rate of treatment failure, be that because of antigen escape, i.e. loss of CD19, or because the T cells themselves become exhausted. And so some ways of thinking about overcoming the failure and overcoming the kind of the rates of failure with CAR T cell therapy, including the design of CAR T cells that may target 2 antigens on the surface of the malignant B cell. So not just CD19, but also CD22, for example, in this example, and also potentially using allogeneic CAR T cells. So T cells taken from healthy donors, where you can do this in a pre-planned way, that you can take the allogeneic T cells off the shelf and you can give these to patients in a very short time frame, so you don't have to worry about the manufacturing from this. So we're kind of beginning to explore more how we may be able to refine our CAR T cell offering to make this better for patients. Of course, for those patients, unfortunately, who do not benefit from CAR T cell therapy, giving further treatment can often be difficult, particularly because of the cytopenias and the fact that their disease is so refractory. And unfortunately, the outcome for patients who are failed by CAR T cells is really disappointing. And there's a big focus on therapies that we can offer potentially now for patients who relapse after having had CAR T cell therapies. So let's go back to our treatment algorithm. We've dealt with those patients who have early relapse and who are fit enough for CAR T cell therapy. We've dealt with the fact that on the other side is patients who have had a late relapse and who are fit enough for stem cell transplantation. In the middle is a group of patients who are unfortunately not fit enough for any of these more intensive procedures. Now that's getting quite small now, particularly for the CAR T cell patient population, but not necessarily quite so much for the high-dose chemotherapy population, and for those people who potentially relapse. And there are a number of different approaches, which I'm just going to whistle through quite quickly for us to have a think about where we might be able to engage some new agents along with some of those things that have been available for a little bit more. And I think there's a lot of excitement because there's a lot of new potential targets and a lot of new drugs that are being looked at in relapsed and refractory diffuse large B-cell lymphoma. Not all of these may be available in the countries that you may be working in. So what about conventional immunochemotherapy? Well, we've seen regimens such as R-GemOx, R-bendamustine, etc., for those patients who relapse after stem cell transplantation, or for those patients who have been unfit. And unfortunately, whilst we may see complete response rates that may be sort of 50% or thereabouts, the durability of benefit is really very limited. Polatuzumab you've heard about in the previous talk is an antibody drug conjugate which targets CD79B on the surface of the malignant B cells. And it carries with it a cytotoxic payload, that's MMAE, or monomethyl auristatin. And MMAE is the cytotoxic payload which is carried in the other antibody drug conjugate that we're very familiar with, brentuximab vedotin, which we use for Hodgkin's and anaplastic large cell lymphoma. So essentially, this is an antibody targeting CD79B that essentially delivers a cytotoxic molecule directly to the malignant B cell. It's cleaved from the malignant B cell once it's internalized in the pH environment of the lysosome, and it results in release of active cytotoxic, which is a tubulin inhibitor, which basically causes microtubular disruption and then causes an apoptotic catastrophe and cell death. Now, on its own, in relapsed and refractory DLBCL, polatuzumab has a good response rate, and also in combination with rituximab, but the CR rates are pretty low. So the approach in clinical development was to partner this with chemotherapy, and the chosen chemotherapy backbone was bendamustine and rituximab. And in a small randomized study, bendamustine and rituximab in patients with relapsed and refractory DLBCL was compared with bendamustine and rituximab in combination with polatuzumab. And the addition of polatuzumab increased the complete response rate from about 18% to about 43%. And it did this with minimal increase in toxicity. There was perhaps some more neutropenia, but this probably wasn't associated with much in the way of increased risk of febrile neutropenia, and certainly was associated with some increased risk of peripheral neuropathy, being a microtubular inhibitor. And actually what we've seen in this group of patients who were considered ineligible for high-dose chemotherapy was that progression-free survival and overall survival can be significantly increased compared with just when polatuzumab is added compared with bendamustine and rituximab on its own. And in fact, overall survival was increased 3 to 4-fold by the addition of polatuzumab to bendamustine and rituximab. So this has been a really useful agent to add to our armamentarium. Now, another antibody drug conjugate is loncastuximab tesirine, which targets CD19 on the surface of the malignant B cell and has a different cytotoxic payload. This is a PPD dimer, which is basically a DNA minor groove binder, which causes cytotoxic cross-linking and interstrand DNA breaks, which essentially results in cell death. And this drug, Lonca-T, when given to patients with relapsed and refractory diffuse large B-cell lymphoma, has been associated with a response rate that neared 50%. Of about half of those patients achieved a complete remission, and it was associated with a pattern of toxicity. It was a little bit different based on the fact that it's a PPD dimer. So we see some abnormalities of liver function tests, some photosensitive rashes, and some third spacing. But this drug is very, very interesting. It's been associated with some highly durable complete response rates. And actually what's quite interesting about the drug is that actually it seems to work in those patients who've had prior CAR T-cell exposure. So although they've already had a CD19 directed therapy, it seems to work in that group of patients. So in those patients who previously received CAR T-cell therapy, about 46% of patients responded to it. So Lonca-T is currently going through the NICE evaluation process in the UK. Tafasitamab is a CD19-directed antibody, but this is different. This is not an antibody-drug conjugate. It's just a naked antibody which has been humanized and is able to engage immune effector cells, such as natural killer cells and phagocytes, to cause direct cellular death. So there's no payload here that goes with it. And actually, what was really interesting that tafasitamab, when looked at in the laboratory with lenalidomide, seemed to be synergistic in activity and increased ADCC activity. So interesting combination. And in the L-MIND single-arm phase 2 study in patients who had relapsed diffuse large B-cell lymphoma, the overall response rate was some 60%. And actually, some of these benefits appeared to be durable. And we saw that in some cases, you see a prolonged progression-free survival for some of these patients. However, when this has been applied in the real-world setting, the outcomes for tafasitamab unfortunately have been disappointing. And actually less patients with tafasitamab in combination with lenalidomide, less patients achieved a good response, and the duration of response was less good. Now, this was a single-arm phase 2 study that was presented as the pivotal data, and unfortunately the evidence was not strong enough for this to be supported by NICE in the UK, but it is available in other territories for patients with relapsed and refractory diffuse large B-cell lymphoma. A lot of interest and a lot of excitement about the bispecific antibodies. Bispecific antibodies are single molecules that target multiple antigens, and they come in different forms, and they have different characteristics which affect their stability and their binding affinity and perhaps their clinical efficacy. Some bispecifics are single chain variable fragments, so these very small molecules. Some of these are based upon an IgG format, and they may have an Fc component which is inactivated, and certainly we know that having an Fc component is associated with an extension in terms of the half-life of the bispecific antibody. But essentially in this cartoon, really what we see is that bispecific antibody brings together two different cell types, and the format that we are seeing in the later stages of clinical development are the CD20 by CD3 bispecifics. So on this antibody we have a CD20 which binds the surface of the malignant B cell, and we have a CD3 binding site which binds a component of the T cell receptor, and it brings the T cell and the tumor cell into close proximity so that a synapse can be formed and induces T cell mediated killing of the tumor cell. So this is a way of engaging T cells to come in close apposition with the tumor cell and to result in cell death. And there are a number of different products that are in development. The two that are in the later stages of clinical development are epcoritamab, which is given by a subcutaneous formulation, which is given until disease progression in relapsed and refractory DLBCL, and glofitamab, which is given by the IV delivery, but is given as a fixed duration of therapy for some 12 cycles. And you just see here on this graph different ways that they're being delivered. What's really interesting about the bispecific antibodies that in the third line setting, that in with DLBCL, so having failed 2 prior lines of therapy, the complete response rate in the pivotal studies is about 40%. In fact, for epcoritamab was 39%. And it seemed to work across all different subgroups of patients with diffuse large B-cell lymphoma, including patients who have previous CAR T-cell exposure. And similarly, in the pivotal study of glofitamab, the complete response rate was also 39% in a sample size that was very similar. And what's very interesting about the CAR T cells is not only that the fact that their complete response rate is high, but actually that the durability of benefit from those patients who achieve a complete remission actually is very good. So if you're one of those patients who's fortunate enough to achieve a complete remission, actually we recognize that those complete remissions appear to be highly durable. I think this is really exciting data from a treatment that can be delivered relatively easily, although there are some particular challenges during the first cycles or so. So one of the commonest toxicities associated with this, recognizing that it's a T-cell engaging therapy, is that patients may develop cytokine release syndrome. And that may occur in up to 50% of patients. The majority of that is very low grade and grade 1, which is just a temperature, but some of those, the cytokine release syndrome can be much more significant. So some of the strategies have looked at admitting patients for observation after they've had bispecific antibodies. Some strategies have looked at giving obinutuzumab to preload and to mitigate against cytokine release syndrome. But actually all the bispecifics have started with a step-up dosing. So we start with a smaller dose and build up over the first few weeks of treatment to mitigate against the risk of cytokine release syndrome. So it takes a couple of weeks to reach the target dose. And what we do recognize is that cytokine release syndrome occurs within the first cycle of treatment almost invariably. And so what we have to do is we have to educate and instruct our patients and their carers about what to look out for, and to ensure that they have a clear pathway of access so that they can access appropriate therapy for cytokine release syndrome should they develop it, including the ability to access tocilizumab. The bispecific antibodies are being used in combination now with chemotherapy, and there's a number of studies ongoing looking at even in the frontline setting in combination with R-CHOP chemotherapy, and also some really interesting studies that are looking at older patients with diffuse large B-cell lymphoma who are probably not fit enough for chemotherapy, or who have a significant contraindication, and instead of using chemotherapy, using a bispecific antibody in the frontline setting. So I think we're going to see a greater role and a greater expansion of bispecific antibodies over the coming years. So for relapsed and refractory diffuse large B-cell lymphoma, conventional approaches have in the main been very disappointing, and we've been striving for an era where we have a range of alternative therapies. This is a new era. There's been a significant paradigm shift in our treatment algorithm, and we do have more options for patients, and we're beginning to see how successful those options are. The cellular therapies are clearly highly successful now that we're adopting them earlier in the treatment algorithms. There's a clear role for antibody drug conjugates, and there's a great promise to be had from bispecific antibodies. There's still much work for us to do in order to better understand when we should use each one of these different products, and how we might optimize the sequencing, and how we may get to the point of delivery of all of these therapies with appropriate bridging. Thank you very much for listening.